For years and years, these patients, they came to our clinics. They asked really complicated questions. They asked about possible treatment options for them. All they wanted was to preserve their kidney function and delay complications for themselves. And by complications, in this case, we are talking about dialysis and need for transplant. We were using off-label medications based on our KDIGO guidelines. We didn't have any FDA-approved medications for these patients. And some patients responded, some patients had multiple relapses over time. And as I said, the risk of ending up on dialysis for patients with this kind of disease is kind of high. And that's something that patients had to deal with it. We have two newly FDA-approved medication. One is iptacopan. Iptacopan is a factor B inhibitor, and the other medication is pegcetacoplan. Pegcetacoplan is a C3 inhibitor. So both of these medications, if you look at the pathophysiology of the disease, both of these medications from the pathophysiology of the disease make sense. That should kind of help us to delay complications for these patients. Both of the clinical trials on these medications showed that they actually significantly drop the proteinuria, meaning that the amount of protein in the urine drops once you take these medications for these patients. A lot of unknowns about these new medications for these patients. How long do we need to continue these medications? Is that going to be a short term or is going to be a long term treatment for these patients? Which patients going to benefit from interval treatment, meaning that you start them on treatment, they respond really well. Are you going to taper them off and see that if they're going to remain stable, or because this is a complement pathway issue, you're going to continue that for the rest of their lives for higher risk patients? The long-term safety data, these medications, they're going to suppress immune system, and any medication that works on the complement system, it increases chances of getting encapsulated infections, including meningococcal infections. Meningococcal infections are really rare, but if it happens, it could be deadly. So that's a really severe potential side effect of these new medications that we have to discuss with these patients, especially for patients that probably they're going to need it for a longer term because they have more aggressive disease or they've had multiple flares in the past. So they have to get vaccinated and they have always to be careful about possible severe infections in their lives. And that's another aspect of treating these patients because they're already dealing with a rare disease. They don't have a huge community to support them. Um, no one talks about it on a daily basis, as you see. Like, we do see a lot of education about diabetes, about hypertension. We do see a lot of education even about different kinds of cancers. But I don't think it's normal to hear about C3G all the time. And these patients, they feel really isolated. Then they take medications that the side effects can be even more isolating as well. So these are the factors to keep in mind. But at the same time, we are dealing with a disease with high risk of complications in the future. So these are really tough conversations with the patients. But on the bright side, now we have FDA-approved medications for these patients, and that feels really good. When the patient comes in, you do have options for them, and you discuss two different options, and then you can have a shared decision about which medication you want to try, which medication fits your lifestyle better. They have options. If they're not tolerating one medication well, you have another option to switch the patient to another medication. And it's bringing a lot of optimism to our patient community, and it's bringing a lot of optimism to us as nephrologists as well, as we might be able to delay complications for these patients from now on. So C3G recurrence is really common after kidney transplantation, and it's reported as one of the leading causes of basically kidney transplant failure in transplanted patients. There was like a study that they had 21 patients with C3GN, and they actually followed up these patients after kidney transplant. And disease occurrence actually happened in 14 patients. So that's really high, shows that how high risk is it that you're going to have a recurrence even after transplant. So it was about 66% of these cases, they had recurrence after transplant. And the recurrence, the median time for the recurrence happened in 28 months. That was the median time. So basically, recurrence can happen at a higher rate comparing to other diseases, other glomerular diseases that we are dealing with. And it sounds like it's not going to take that much time for C3G to come back on transplanted kidneys as well. The median time of 28 months after receiving a transplant is not considered a long time. In many other literatures, we usually see a number higher than 50% chance of recurrence after a transplant as well. So you might say that, oh, okay, so we do have FDA-approved medications for these patients. They're going to go back on the medications as well, and probably the problem is solved. The problem is that, again, our patients, they're dealing with a rare disease. They go through kidney failure and then they receive a kidney transplant. So that's bringing a lot of hope to them. I mean, I can't count the number of times that I've seen my patients crying the night before transplant, the night after transplant. It's a gift of life, right? So for patients who've been on dialysis, who've been dealing with symptoms of kidney failure, receiving a brand new kidney, that's the beginning of a new journey. And then you're hoping for the best after the transplant. And then you're dealing with a rare disease that not only affected you on your native kidneys after receiving the transplant, after going through like so much of evaluations, complicated surgery, finding a donor, then it might come back with a really high chance. So we really need more research on post-transplanted patients. So we do have a lot of questions about these high-risk patients that should we wait until the disease comes back and then treat these patients? Should be more proactive about treating C3G in these patients that are receiving transplant? And these are the questions that we don't have good answers for them, and we need more data, we need more clinical trials. Having two FDA-approved medications for these patients, again, is bringing a lot of comfort and a lot of optimism to these patients. They're going for a transplant. They always ask me that, do you think that the disease can come back? And for years and years, we said yes. If it comes back, we're going to try our best with the medications out there. But our answer have changed this year. And we said, like, if it comes back, we will have FDA-approved medications for you. And hopefully they're going to work and hopefully they're going to control your disease. And the data so far is really promising. And I think that's a great thing to have at least two options for these patients. Are we done with treatment options for C3G? Obviously not. And I'm hoping to see more options in near future, more clinical trials. I know it's a rare disease, but I always say that it's rare until it happens to your friend or family members or to yourself, and then it's not rare anymore. You want the best treatment options out there, and you always look for a cure for your loved ones or yourself.